private place on the East Coast somewhere, I heard?
It's growing.
It's growing, thank goodness. All right. And Dr. Sandeep Patel, Professor of Medical Oncology and leader of everything medical oncology at the University of California in San Diego.
Great to be joining you.
Thanks for coming to a surgical meeting. We're excited to have you.
I'm enjoying it thoroughly.
Okay. All right, and thank you to all of you. We have attendance both in the room and online. We thank PeerView for providing us with this session, and we thank AstraZeneca, BMS, Merck for providing us educational grant for this symposium. If you haven't already done so, please complete the pre-event survey so we know who you are and so that you can engage with the app. Look out for additional polling questions during the presentations, and we ask that you please submit your questions for us online. We will have a mic in the room, but it's much easier for us to interact with the online audience if those are done on the room. There will be a QR code for you to scan, and there will be prizes for the best question. So this is the QR code, so I ask everybody to pull your phones out and scan it. This becomes the best way to interact with us and to answer our questions. We do have Amazon gift cards for the best questions. We used to do it for the most, but then some people just submitted the same question over and over again. All right. When this is over, we ask you to please visit peerview.com. This will be posted under the Immuno LA 25. You will be able to see slides and all of the discussion. So our goal for this evening is to enhance your understanding of the latest evidence supporting the use of immunotherapies in resectable non-small cell lung cancer. We want to augment your skills in identifying candidates for neoadjuvant, adjuvant, and perioperative immunotherapy. And we really want to improve multidisciplinary collaboration. We believe that is really key to properly integrating immunotherapies for individual patients with stage 1 to 3 non-small cell lung cancer. All right, so I think I'm starting the educational part, and I'll go over to the kind of basic story here for immunotherapy and give us some key data and real-world practices. So we'll start with the key evidence. So these are the 6 current approaches that have been FDA approved here in the United States for using immunotherapy in resectable lung cancer. We have neoadjuvant immunotherapy with chemotherapy based on the Checkmate 816 trial. We have adjuvant immunotherapy in the form of atezolizumab or pembrolizumab based upon Empower 010 and Keynote 091 trials. And then we have 3 peri-adjuvant regimes which are approved, one with durvalumab, one with nivolumab, and one with pembrolizumab. All of these are very similar in that they have 4 cycles up front with chemotherapy, then surgery, and followed by a year of single-agent immunotherapy. So lots and lots of options for surgical patients. This very large and confusing table, it used to be color-coded, but is designed not to compare one trial to the next, but hopefully to demonstrate to you how incredibly similar these trials actually are. While they do happen in the adjuvant, neoadjuvant, and peri-adjuvant space, each one of them is a randomized phase 3 trial that pairs a single agent, PD or PD-L1, and I believe from a surgical standpoint, you can consider that absolutely the same, but it pairs one of those agents with platinum-based chemotherapy. The only trials that didn't require the pairing were the Keynote 091 and the BR31, both adjuvant trials where it was suggested but not required. All of the trials were for the same exact population of patients. What is now stage 2 and 3 resectable disease, it's really that the staging changed during the course of these trials, not that the populations changed. And all the trials really did contain a mix of both stage 2 and stage 3. All the trials use a primary endpoint of what I would call a recurrence-based endpoint. Things like disease-free or event-free survival, where if the patient recurs or the patient doesn't go to surgery, that is considered an event. Most of the trials then also paired that with a pathologic endpoint, whether that be past CR, no residual tumor, or major pathologic response, a 90% tumor kill. The only standout trial there would be the Keynote 671 trial. It is the only trial that had overall survival primary endpoint, and that does make it unique in the group. You can also see, if you go from one side to the other, EGFR and ALK patients. So some of the earlier trials, the adjuvant trials, included those patients, and that's because they started so many years ago before we had things like Adura and Alina. But I would say now most of the trials exclude these patients, and all trials in the space going forward will. This funny-looking graph compares the length of treatment and our current follow-up. So the green bars are the length of treatment. And I think this is important when we look at surgical patients. So the standout trial here is Checkmate 816. 3 doses, done and dusted, all before surgery. All the other trials, the treatment is really for at least a year on the adjuvant trials and for up to 18 months on the peri-adjuvant trials. Next are the purple bars. That is the current length of follow-up that has been reported for the trials. And you can see things like Empower, Keynote, and Checkmate all have follow-up now through 4 or 5 years. That's a pretty long time, and we're starting to see most of our recurrences happening. The peri-adjuvant trials, Aegean, Neotorch, Keynote, and Checkmate 77T, those are far less mature, we say, meaning that we haven't maybe seen the full benefit of some of the adjuvant portions of their treatment because many of the patients had just started or maybe just finished that therapy when the trial reported out. This is something that won't change as trials mature. This is the pathologic response from the Checkmate, Aegean, Keynote 671, and Checkmate 77T trials. And again, I don't want you to compare one to the next. I want you to appreciate that in every one of these trials, we see a dramatic improvement in the number of patients who have a pathologic complete response. And we can expect somewhere between 17 and 25% of these patients will have a path CR, no residual tumor in their specimen. This is kind of tenfold compared to what we see with chemotherapy alone. This looks at the disease-free or event-free survival from each of the trials, with the blue arm being the study arm and the yellow arm being the chemo alone arm. Again, not to compare head to head, but to recognize that in every one of these trials, we see improvement. Now, the magnitude of that improvement does vary between approaches, but within the perioperative, those are all fairly similar. And I think that's an important concept here, that this isn't just one small trial showing us an advantage, but each and every one of these similarly designed trials show us this impressive improvement in disease-free or event-free survival. So what about overall survival? These are surgical patients. They are curable. Isn't that the endpoint we really care about? And I agree. I think it is the important endpoint, but it takes a bit of time to get to that endpoint, and we haven't seen it from all the trials. We have seen it now from Empower 010. This is a trial looking at adjuvant atezolizumab, and earlier this year we got the 5-year overall survival. And we do see an improvement in overall survival with the addition of atezolizumab after surgery for patients who are PD-L1 positive. So they have to have PD-L1 in their tumors to see this advantage. And the reality is the group that really saw the greatest advantage were those with a high expression, greater than 50%. And that is an impressive improvement in overall survival. Half as many patients died if they were able to get the atezolizumab and they were high expressors. This is Checkmate 816. This trial is now 4 years out, and we can see an improvement, but not significant. And this is a pretty small trial, only about 350 patients, and while the curves separate, that is not a statistically significant survival advantage overall or for lung cancer specific yet. Aegean, kind of the same thing. We're starting to see curves that separate, but not significant yet. But this is a trial that we only have follow-up a little less than 3 years, and our curves are really starting to separate at 3 years. So will this look different in a year or 2 years? It might, and we are optimistic that we will see that difference. This trial is the standout, and this is Keynote 671 with pembrolizumab perioperatively. This was the only trial that was designed to find an overall survival advantage, and they did. They found it on their first look, and that has made it a really important trial. And this is, again, even at the first look, this is an important improvement in overall survival compared to chemotherapy alone. So what's the impact of immunotherapy on quality of life? I told you earlier that some of these patients are being treated for 18 months. So you're going to take a stage 2 patient who may otherwise get no therapy and suddenly treat them for 18 months. I think quality of life is important. So here's a super boring slide looking at quality of life with perioperative pembrolizumab. And we basically see lines that go straight down the middle. What does that mean? It means that giving this medicine to these patients for a year after surgery doesn't really impact their quality of life. That's a boring but super important finding. And I think this is something you're going to see from all of these trials. This is quality of life with Checkmate 816, the neoadjuvant nivolumab trial. This looks a little more closely about the time around surgery, but whether you have thoracotomy or you have a minimally invasive approach, these patients recover pretty quickly from surgery, and their quality of life is no different than patients who got chemotherapy alone prior to resection. And the same is even true whether they got a lobectomy or a pneumonectomy. Clearly, the pneumonectomy patients have more of a change around surgery, but they all come somewhat back to their baseline. And then finally, Checkmate 77T, they had this curve which looks at time to distant disease and related symptoms. And it kind of highlights the fact that as long as patients don't recur, they tend to do well in terms of their symptoms, and therefore preventing recurrence is important in preventing symptoms, and that was clearly better with nivolumab as compared to chemotherapy alone. So I do think quality of life information is important here. This is a kind of a new concept for us, and that is one way we're going to hopefully continue to improve quality of life is that these medications are now becoming available subcutaneously, meaning that you don't need an IV to give these medicines. So for the preoperative stuff, when they're getting chemotherapy, that might not matter so much because you already put the IV in them and they're already in the infusion center. But for that year of therapy after, the fact that we can now get nivolumab and atezolizumab as a sub-Q injection that takes 5 minutes and they're home again, this is pretty nice. And I think this will only continue to really help our surgical patients. I think from here, I'm going to ask you all to get the QR code and go through some questions as I pass the pointer on to my partner, Dr. Patel, to go through the next portion of the talk.
Great introduction. Thank you, Dr. Donington. And so I'll be talking about comparing immunotherapy strategies and considering some of the subgroups that we see in resectable non-small cell lung cancer. In particular, how do the neoadjuvant and perioperative immunotherapy strategies compare? There's not a pivotal study that addresses this comparison. However, there was a patient-level analysis presented at World Lung in San Diego in 2024 by Dr. Ford that looked at Checkmate 77T, the sandwich approach, as Dr. Donington kindly refers to the perioperative approach, versus Checkmate 816, which is the pure preoperative 3 cycles of chemo-IO approach. So the patient-level analysis, probably the closest we're going to get to at least maybe not an apples to apples, but an applesauce to applesauce comparison of these therapeutic strategies. And what we saw is that there was an event-free survival benefit to perioperative nivolumab, meaning giving chemo IO up front followed by a year of nivolumab, which can now be given subcutaneously, versus a pure 3-cycle neoadjuvant chemo IO with a hazard ratio of 0.61 in the weighted analysis. Now, what's interesting, and probably not surprising, is that the bulk of the benefit of giving that back-end nivolumab, that year of therapy afterwards, was really in the patients who did not achieve a pathologic CR. Those patients that achieved a path CR on 3 cycles, hard to improve on perfection. And you see here on the left survival curve. But those patients that did not, potentially there's a benefit to extending nivolumab for up to a year. Now, when we look at patients who may have had an added benefit, PD-L1 expression, the biomarker strategy may make sense in terms of differentiating those patients that may benefit from continued IO versus not. And it seemed like those patients that are PD-L1 negative had benefit from extension of nivolumab into the perioperative setting. Meanwhile, those patients who are PD-L1 greater than 1%, they often had a path CR, they often had sufficient therapy with their purely preoperative approach. And so we're seeing, based on this data, that potentially patients who are PD-L1 negative, potentially patients who do not have a path CR, may benefit from continuation of their nivolumab. And then what about stage? Well, it turns out, very interesting, IO mitigates the negative prognostic aspect of stage if you get a response. And so if you're a stage 3 patient, get a nice response, you can do quite well, both with the neoadjuvant perioperative approaches. And so maybe something to think about in terms of node positive versus node negative. By stage, we don't see a big difference with one approach versus the other. And so we see those patients, so we talked about the nivolumab data. What about Keynote 671? This is the perioperative approach, chemo-pembro followed by pembro for a year. And this is the one study we have overall survival data mature for. And we see that those patients with a path CR have a really nice hazard ratio of 0.38. Meanwhile, those patients without path CR have a hazard ratio of 0.64. And so even those patients that don't get 100% tumor kill, and even if you get 90% tumor killing, which is a major pathologic response, or MPR, those patients can benefit, though here we don't have the comparison of those patients with a pure neoadjuvant approach versus the perioperative approach. Now, when we look further into the Keynote 671 data, we see here in the bottom left and the bottom right that those patients that had pembrolizumab, independent of RVT or residual viable tumor, these patients got the full perioperative approach, and even if they had viable tumor, these patients could benefit from continuation of pembrolizumab, though this is not a comparison to neoadjuvant versus perioperative like we were discussing earlier. And similarly, this is an exploratory analysis from Checkmate 816. And those patients that had up to 95% tumor killing, they actually reasonably did quite well. 90% continued to be disease-free up to 2 years. Meanwhile, those patients that had over 80% residual viable tumor, they actually did quite poorly. And so these are patients that likely will benefit from intensification strategies from non-IO based modalities, for example, antibody-drug conjugates, potentially groups that may benefit from radiation. And so this is a continuous variable. And while pathologic complete response, which happens in about a quarter of patients, represents 100% killing of tumor, we unfortunately in real life see patients who are in these intermediate strata and have to figure out what to do for these patients. And I think for most patients, anywhere from 5 to 30% tumor killing benefit from continuation. But I think if you have more than 80% residual viable tumor, the very definition of insanity is continuing the same thing and expecting a different result. These are patients that we really need to think about alternative therapeutic strategies for our patients for. And so how should we tackle these specific subgroups? So in the Aegean study, which looked at chemo durvalumab followed by durvalumab for a year, so a perioperative approach, we see that pathologic complete response rates, very similar to what we saw in the other studies, and major pathologic response, meaning greater than 90% tumor kill or less than 10% residual viable tumor, occurred in about a third of patients. So really a clinically meaningful benefit. Now, what's interesting is whether a patient was single station versus multi-station, we did see a difference in pathologic complete response and MPR rates, which may indicate that potentially selecting for those patients with more oligo nodal disease, these patients may potentially do better, and kind of going to the convention at many institutions, that's really single station, non-bulky, that are the best surgical candidates. There were some exploratory analyses looking at N2 single station versus multi-station, though, from a survival standpoint, and there's a bit of a disconnect. I showed you earlier the pathologic complete response rate difference. But when you look at N2 multi-station and N2 single station in the Aegean data set, the survival hazard ratios are actually quite similar, 0.61 to 0.69. So at least hypothesis generating as we think about potentially making multi-station N2 disease operable, though there is a disconnect between pathologic complete response rates and event-free survival, and the standard of care for many of these patients outside of clinical trial remains the Pacific regimen of definitive concurrent chemorads followed by a year of durvalumab. But tantalizing data, at least for multi-station N2 disease. In Checkmate 77T, this is the perioperative nivolumab approach. We see that patients with N2 disease actually had pretty similar path CR rates compared to those patients with non-N2 disease amongst the stage 2 setting. So the idea that nodal status may not be the end-all be-all for patients, at least who respond to IO, but understanding which patients will respond versus not very much depends on the PD-L1 status, the lack of EGFR-ALK, maybe other factors like tumor mutational burden. But the idea that this may be an area for clinical trials where multi-station N2 can benefit, but you have to select those patients, at least based on biomarkers that have a propensity to respond. Otherwise, you're not only losing a surgical opportunity, these patients are going to have a much more complicated radiation course due to a progression of disease in a larger radiation field. We see here multi-station N2 in this Checkmate 77T analysis. There's actually a 37.5% pathologic complete response rate, which is actually higher numerically than single station. How much of this is patient selection right upstream, maybe patient fitness, I think remains to be seen, but at least tantalizing data that multi-station N2, if you can find patients that respond, you can achieve a pathologic complete response. And so really an area that's hypothesis generating for advancing the standard of care and thinking about can we select for patients who may be good operative candidates even that are multi-station. And we look at the event-free survival, which at least is overall survival being the gold standard, but event-free survival where we have data that's mature. We see here for N2 disease that these patients do quite well, quite similarly actually to those with non-N2 disease with the hazard ratio. And in single station N2, EFS hazard ratio 0.49, multi-station 0.43. So again, slightly different agent, but similar result, PD-L1, PD-1, perioperative approaches. These patients have similar benefit of multi-station N2. So if they're resectable, something to think about, especially in the context of a clinical trial where we have some tantalizing data that we can potentially operate on these patients. Would I consider this for a patient with a driver mutation? No. Am I enthusiastic about this for a patient with a PD-L1 0 with a TMB low? Probably not. But for patients with high PD-L1, high TMB, it's definitely worth considering. When we look at landmark EFS from definitive surgery, you actually see that N2 multi-station here with the nivolumab perioperative program have a hazard ratio of 0.23. It's actually the best hazard ratio amongst all of these patients. So I think what I take away from this data set really is if you can get a response with IO, nodal status is really obviated as a negative prognostic factor. The immune cells will get into multi-station lymph nodes as easily as they will be single station, but that negative prognostic factor for patients up front and whether host factors may drive them more to a Pacific approach with concurrent chemorads versus surgical approach, these are the discussions we have to have in clinic. But if you can get a response in patients, they'll do just as well with multi-station N2 as they'll single station. The big question, the million-dollar question, how do you predict who those patients will be? One area that's very active and ripe for research is using cell-free DNA for monitoring. Imaging, often with chemo-IO, does not recapitulate the totality of radiographic response. In fact, we can get nodal flare with response to the primary lesion where the lymph nodes look worse, but in fact, those lymph nodes are chock full of good immune cells and don't have any tumor in them, and so those patients actually should proceed to surgery, and they'll actually do generally quite well when they're on neoadjuvant chemo-IO or on a perioperative approach. Cell-free DNA may be one way of tracking this phenomenon, and we see here, which makes sense intuitively, those patients that have cell-free DNA clearance while they're getting neoadjuvant chemo-IO are the ones that tend to do better. Meanwhile, those patients who do not clear tend to have resistance, which will be seen by imaging, and may need other strategies such as ADCs. We see here with the chemo IO, with the 3 cycles of chemo-nivo up front, the cell-free DNA clearance very much recapitulates what we see in terms of overall pathologic complete response rate and event-free survival. Those patients with clearance we see have the best overall survival. Meanwhile, those patients with no clearance at all tend to have residual disease, tend not to do well, and have the poorest survival. So a potential area that can break ties in terms of imaging and a potential early snapshot for patients who can benefit and maybe pivot into other strategies. For example, maybe giving a cycle or two chemo-IO up front, getting that imaging study, getting cell-free DNA, and using the totality of data to determine whether we should continue down that path, whether the patient should go to surgery, or maybe the patient unfortunately has progressions, not a surgical candidate, can bridge over to a locally advanced therapy, concurrent chemorads, followed by IO. And this slide kind of shows that you can get ctDNA clearance, and those patients that do not clear, which is on the far right, they do no better than on placebo, right? So we should spare those patients surgery. They're going to relapse, especially if it's a pneumonectomy. Meanwhile, those patients with cell-free DNA clearance tend to do better, but it's not the end-all, be-all for those patients. So I think this will be an important piece of the puzzle in the future, especially as these assays become more sensitive, especially as their turnaround time starts to approach 5 to 7 days, but it's not going to be the whole story. And so with that, please take a moment to answer the polling questions by QR code. And now happy to hand over to discuss practicalities and considerations of integrating immunotherapy, Dr. Broderick.
Perfect. Thanks, Dr. Patel and Dr. Donington, and thank you, Peerview, for the invitation. A little bit less data moving forward and a little bit more consideration of some of the nuances in how we actually integrate these medications into the perioperative approach to our patients. So what we're trying to do is combine local therapies with systemic therapies to give the patient the highest chance of cure. And so the local therapies, generally speaking, are surgery and radiation therapy. And what we're looking for there is local and regional control. So removing the primary tumor plus the sort of local regional lymph nodes, hilar and mediastinal lymph nodes. Systemic therapy, on the other hand, chemo, targeted immuno, to reduce the risk of distant relapse. So treat micrometastatic disease, and then from the immunotherapy standpoint, prime the immune system to sort of survey for recurrence and take out any cancer cells that we may not be able to see with our current imaging studies or even with ctDNA. The last quarter century or so has seen unbelievable progress in the care of patients with non-small cell lung cancer. And so on the top part, sort of the medical oncology world, we've seen dozens upon dozens upon dozens of drugs year after year after year, all of which have made incredible impacts on how we take care of patients with systemic disease. But that's not been the only progress. We've also seen advances in patient selection, not only with imaging studies and staging modalities such as PET-CT and EBUS. We're integrating molecular testing at hopefully the earliest levels, right at diagnosis now. We've also seen better surgery. So in the surgical community, we've made a lot of progress with minimally invasive resections, lessening the impact on quality of life, ERAS protocols so that patients are spending less time in the hospital and getting back to sort of normal function faster, or recovering from surgery fast enough to move on to their next line of systemic therapy. And now the integration more globally or more frequently of sublobar resections. And so our job as a lung cancer community now is to put all of this together to optimize outcomes for our patients. So what do we need to know and what do we need to do to accomplish that? First and foremost, we need to pick the right patients. We need to know for whom these combinations of therapies are appropriate oncologically, but also physiologically and from a social standpoint in an individual patient's life. We need to determine the best sequence of therapy for an individual patient. We need, and this is really incumbent upon surgeons, appropriate pre- and intraoperative nodal staging is crucial here. As surgeons, we need to understand the evidence and understand it well enough that we can relate it to our patients and to their families in terms of explaining to them how and why we're making the recommendations that we're making. And then from a technical standpoint, know what neoadjuvant therapy in particular may sort of lead to in the operating room and be prepared for those eventualities. Patient selection considerations, so the surgeons all are familiar with this from a staging standpoint, CT, PET, invasive mediastinal staging, most of the time by EBUS, occasionally mediastinoscopy or VATS. All of these patients with locally advanced disease should have a brain MR. Physiologically, we're looking at pulmonary function, cardiac evaluation, sometimes exercise testing, and frequently frailty assessment as we're diagnosing many, many more patients in their 70s and 80s now. And that's going to play an important role when we're talking about potentially 18 months of therapy in an octogenarian. What's their frailty status? And then early biomarker testing, specifically EGFR and ALK, but now even more so recently, next generation sequencing or more broad sequencing panels for other genomic alterations that will impact therapeutic options, and then PD-L1. So how do we pick? It looks pretty straightforward. There are anatomic considerations regarding the extent of disease, so the stage, TNM, right? Are the nodes multiple nodal stations, bulky? Is there extranodal or extracapsular extension? What's the size of the primary tumor? If there is metastatic disease, is it multiple sites, or is it oligometastatic disease? Does the patient have a solitary brain met that we can deal with? What's necessary to resect that tumor? Do we need a pneumonectomy? Do we need some sort of advanced reconstructive technique like an angioplasty or bronchoplasty? What is the histology and the biomarker assessment of that tumor showing us? Really, what's the biology of the tumor, and how does that impact what decisions we should make? And then patient considerations, age, performance status, pulmonary status. Will they tolerate immunotherapy, right? There are contraindications to these drugs, whether it's lung disease or other comorbidities. Will they tolerate targeted therapy? And then if we opted for non-operative therapy and radiation, what does that radiation field look like? And how is that going to affect the patient over the long term? The good news is the surgeons in the room, we don't have to do this alone, right? We need to do this as part of a broad multidisciplinary team, and you can see everybody there. And we need input from all of those specialties in order to make the best decision or the best recommendation for the patient and help them, based on their preferences and their priorities, make a decision. That multidisciplinary team, that multidisciplinary discussion really matters. There's a fair amount of data out there. We've picked two studies here, both retrospective. The one on the left from Australia, where they matched patients stage for stage over, I think, a decade of patients going through their tumor boards. And the patients who were discussed at the tumor board had better survival outcomes than those who were not. And then the same thing from Taiwan. This was specifically in the stage 3 population, and all the patients or among those patients, those who were discussed at the multidisciplinary tumor board did better over the long term. How do we sequence the different therapies? And there are advantages and disadvantages to all the different approaches. So if we're going to go neoadjuvant, particularly neoadjuvant only, the benefits include early eradication of any micrometastatic disease. We're initiating treatment in healthier people, right? They haven't had an operation, they haven't had other systemic therapy yet. More likely to tolerate any toxicity of drugs if we give it to them ahead of surgery. Improved adherence, we usually get all 3 or all 4 cycles of treatment in. There's a great opportunity here, not only for science, but for making treatment decisions where we see the pre- and post-treatment biopsies, and we know if and how the drug worked and to the extent that it worked. This is the standard of care for resectable stage 3 disease currently, and we think that having the whole tumor present with a broad array of tumor antigen allows for a really diffuse and a diverse and robust immune response when we give the checkpoint inhibitors. On the other hand, the adjuvant approach, standard of care currently for stage 1B and 2, that's changing. No surgical delay, right? If you see a stage 2 patient and you say it's resectable, I'm going to take it out, you book it for next Tuesday or 3 weeks from Tuesday in my sense. But as soon as you can, as soon as you have a room and an anesthesiologist and the patient's ready, you're a go. You get tumor biomarkers. So oftentimes in the preoperative setting, we're dealing with fine needle aspirations or percutaneous biopsies, and it's not uncommon that we hear quantity insufficient for NGS. And so when we hand the pathologist or your molecular tumor board, if you have one, that entire specimen, we get the entire biomarker panel all the time. From a surgical complexity status, there's no impact on that from treatment because we didn't give any, so there's no additional hilar or mediastinal difficulty. And we minimize the risk of progression between diagnosis and staging and getting to the operating room. And then there's what some people call perioperative, some people call it peri-adjuvant. Dr. Donington calls it sandwich approach, which is pre- and post-operative therapy. And so we get all the benefits of the neoadjuvant approach, as we discussed in the first part here, but addition of therapy on the back end to continue therapy and get more treatment for the patients. As a surgeon, it's often our responsibility, particularly when we're considering how to sequence or if surgery should be part of the care, and we ought to be doing this up front at the time of diagnosis to assess resectability and unresectability. And so this is a little bit tricky of a diagram here, but across the top bar on both levels are those tumors technically resectable? And most of them are, right? There are some challenges that we come across where we say this is an unresectable tumor from an anatomic standpoint. But those are really advanced situations with bulky nodes invading into critical structures and things like that. But then there's also the question of, is it oncologically resectable? So is there going to be an oncologic benefit to that operation? And I think that's straightforward, sort of to the top and left of those cartoons where we have small tumors, maybe single station nodes that are not invading other structures. But as we get to the bulkier and the multi-station N2, we have some work to do to figure out really what the benefit there is. The data, as Dr. Patel was describing, says there very well may be benefit there in the multi-station patients, particularly when we see response to therapy. But how are we going to be able to predict that moving forward is really the question. These are some sort of common resectability criteria. I think everyone's pretty familiar with most of these. Up at the top of that list is what the patient wants and their risk tolerance, whether they're really wanting to go for this or not, and that's highly variable. Similarly with the surgeons, what's the surgeon's experience in operating in a post-neoadjuvant setting, and the surgeon's risk tolerance. Baseline physiology, we're all familiar with that, PFTs, VO2 max, 6-minute walk, et cetera, and then what are the predicted post-operative functional reserve and quality of life issues that we may encounter. What's the feasibility of an R0 resection at baseline, and what sort of response are we expecting from treatment? I think some debate about that is sort of the aspirational resectability when we see a tumor and we say, well, maybe it's resectable, not really sure, let's give a couple cycles and see how it goes. That's a bit debatable and something that really needs to be tackled in your multidisciplinary setting, whether you're going to take that approach. And then how does the risk-benefit profile of the surgical course compare with the other therapies that are on the table? So if you have a frail patient, maybe older patient, limited pulmonary function, well, what does neoadjuvant chemo-IO followed by surgery look like? But what does chemoradiation followed by immunotherapy look like? And what are those different risk profiles? And then discussing that with the patient and seeing how they feel about those different profiles. We talk often about the difficulty of surgery, of pulmonary resection after neoadjuvant therapy. And that's real. That's a real phenomenon, but it doesn't happen all the time. We're sort of gaining experience with this, and really I think the sense is that it's really hilar nodes, and particularly response in the hilar nodes, that makes for difficult discussions. So the graph on the left is from a study out of Cornell, looking at when the surgeons felt there was moderate or major fibrosis in patients who received an immune checkpoint inhibitor. Only 20% of the time in the node-negative patients and 60% of the time in the patients who were node-positive. And then similarly from MD Anderson on the right side, they found that in patients who received neoadjuvant Nivo or neoadjuvant Nivo plus IPI, about 40% of those operations were in the surgeons, from the surgeon's perspective, felt to be more difficult than the average lobectomy. Checkmate 816, these are the surgical outcomes, looking actually at all adverse events across the study, and there was no difference between chemotherapy alone or chemotherapy with Nivo in the neoadjuvant setting. So on the left-hand side, you see all of the adverse events, whether treatment-related or surgical-related, and no difference, in fact, somewhat lower numerically in the Nivo group. And then on the right side, you see the operations actually took longer in the chemo arm than the chemo-Nivo arm. More of the Nivo cases were accomplished minimally invasive. There were fewer pneumonectomies, more R0 resections. And so the trial wasn't designed for this comparison, but it certainly shows that there wasn't a signal that the Nivo was more dangerous in terms of performing pulmonary resections. This goes back to the idea about the nodal disease. So what are some of the intraoperative challenges after induction therapy? This is the group from MD Anderson again. They looked at a decade's worth of patients who were node positive and treated with neoadjuvant therapy. And one of the main things associated with a difficult dissection and the need to do complex intraoperative maneuvers, whether that's encircle the main PA or do an arterioplasty or any of the sort of things that we do sometimes, it was that clinical N1 disease that really tipped the surgeons off that may be necessary. And if you know that ahead of time, you can prepare for it. This is a case of Dr. Donington's here, and so this highlights some of the technical challenges that we may encounter when we operate after neoadjuvant therapy. So you can see on the top left there, sort of a bulky central right upper lobe tumor. If you look in the bottom there, you see the tumor and probably some hilar nodes coming down onto the central right upper lobe bronchus, approaching the PA. And then a terrific, at least radiographic, response to therapy. I mean, that tumor melted. That doesn't necessarily...
That made me scared.
Yeah, that doesn't mean it's going to be easy. And so what's the thought process going into that case? Well, we're going to think about a minimally invasive resection, but certainly be ready to do this open. We have I don't know about you all, I always have all the open stuff in the room anyway, but we're going to be prepared for an open operation. Who's helping you that day, right? Do you have the third-year resident? Do you have a brand new PA? Or is your partner in the room next door and you're prepared for what you're going to be doing here? Allow adequate time to do this, right? This isn't going to be a 90-minute lobe and boom, we're going to lunch, right? This is going to be work. Dr. Donington started MIS, looked for pleural disease, and then start the dissection and see how that goes. If you're making progress, if it's safe, great. You do a minimally invasive, whether it's VATS or robotic lobectomy, terrific. If not, you convert and you're prepared to do those other maneuvers that we were discussing earlier to do a safe operation. And then, as Dr. Patel mentioned, one other thing to talk about is this idea of nodal immune flare and that your post-treatment imaging may not be sort of accurate in terms of assessing for progression. And so on the left-hand side there, you can see that this patient had a left-sided tumor with some left paratracheal nodes, and then post-treatment, those nodes are bigger and more FDG avid, and now there's even one on the right side, and that all turned out to be benign. That was post-treatment nodal immune flare and not progression of disease. Whereas on the other side, you can see that there's a new node in that anterior mediastinum that's FDG avid, in addition to sort of progression in and around the hilar structures. And that one actually turned out to be nodal progression. So be careful with those imaging studies and really run those to ground if you think that there may be progression on therapy there. But there's certainly a good chance that it's just reaction and the T cell infiltrate doing what we want it to do. So I'll stop there. Again, here's your QR code to sort of pull up on your phone and answer the questions. And then I think we're going to move on to case discussions, Nick.
Right, so I do ask you all to pull your phones out and have them ready because we are going to do cases and we want to ask you guys some questions. So I think the first case is mine, a 63-year-old former smoker with a right upper lobe mass found by a cardiologist. Follow-up CT showed a 3.5 centimeter central mass. Brushing and biopsies on the outside were negative for malignancy, but the PET was pretty positive, and the lymph nodes were not. There were no distant sites of disease. When I saw the patient, I looked at I looked at the CT in multiple angles, and suddenly I had a much bigger tumor than I just saw on the first cross-sectional look. I actually sent the patient for a repeat biopsy with an EBUS, and therefore I could also stage the mediastinum at the same time. The right upper lobe mass was a squamous cell. PD-L1 expression was 60%. On this cranial caudal view, the tumor was, as expected, 4.4 centimeters, and the lymph nodes were all negative. So clinical stage T2B and 0, a stage 2A. That cardiac workup that the patient was getting was all normal, and the PFTs were really quite good. So, what would be your recommendation for treatment in this patient? Resection plus adjuvant chemoimmunotherapy, resection plus surveillance, neoadjuvant chemotherapy plus resection, neoadjuvant chemoimmunotherapy and resection, neoadjuvant chemoimmunotherapy, resection, and adjuvant immunotherapy, or I give up, I don't know. Please scan the code and vote. We will look at your responses. I think while we're doing that, do we get to chit chat? Well, I guess we'll see what they see first. Music. Okay, guys, have to vote or we're going to be listening to this music all night. You know that, right? Oh, thank goodness. All right, so let's see. 50% of our people said they would do, oh goodness, now it's all over the place. All right, so we have a major split. Everything pretty much got voted for. We have about a quarter of patients say resection and surveillance. A quarter of patients say neoadjuvant chemoimmunotherapy and resection. A quarter say perioperative chemoimmunotherapy. And we still have patients who say, I am not sure. That's why we have colleagues and friends to help us out here. All right, so I think I get to ask my colleagues and friends, how would this patient be treated at your institution?
It's a great question. Not all T2 is created equal, and I think the cross-sectional imaging, gives rise to concern around going straight to resection. So at our institution, we would either offer neoadjuvant chemo-IO. The PD-L1 score is 60%. It was squamous, so we didn't necessarily need to test for EGFR-ALK, followed by resection, or a perioperative approach. 4 cycles chemo-IO up front, followed by IO for a year would typically be our management, our institution.
100% agree. I think that as that size grows and you get into the 4.5 range, but also that's a central tumor. And I think there's a real high risk of occult nodal disease, whether they're intralobar lymph nodes or hilar nodes that are sort of beyond the resolution of EBUS. And so we would start with a neoadjuvant chemo-IO approach, and then the decision about the adjuvant component would be made based on the pathologic results.
Right. Would someone be wrong to say that they wanted to go for upfront resection in a node-negative tumor with 60% PD-L1?
I think it's reasonable. You can use adjuvant IO on the back end, of course. I just worry all the features you guys described. Central lesion, it looks larger. Also, sometimes you get multiple scans, you see that growth rate kinetic, right? And so you can make an argument both ways. But I think at our institution, this would be a neoadjuvant or neoadjuvant plus adjuvant chemo-IO case.
Okay. So I'm going to ask you guys to scan again and see whether we totally convinced you to change your vote, totally educated you. We will not wait for the follow-up poll, but I do ask you to vote. It proves whether we're influential or not. I will tell you what we did. I think I lost a slide here, but the patient did go for neoadjuvant chemoimmunotherapy. I really am a believer that I think the responses are more robust in the neoadjuvant setting, and that I really do believe in those armies of T cells which we develop by treating with the tumor in place. Tolerated well, then went to the OR. I was able to do it by VATS. I actually do most of these via VATS now. I mean, I do a lot of these, but it's taken a little while to be comfortable and to say it. And I always talk about open with all of these patients. And if I do have to open, I don't. It's not a sin. It's okay. I forgive myself before I go talk to the family that I had to do it But I've talked about it with my patients beforehand. So this one, there was no residual viable tumor. So YPT0N0, nodes negative, everything was great. She did have a chyle leak, but she got over that pretty quickly and was home on day 7. So what would we do at this point? Adjuvant immunotherapy, adjuvant chemotherapy, surveillance, or I don't know? I ask you please to vote. No music? No.
Cute.
All right. So again, it's a pretty impressive mixed bag of answers. I like this crowd. It's great. So about half of people said adjuvant immunotherapy. Some said adjuvant chemotherapy, surveillance, and I'm not sure. So this has become the new catfight in our tumor board. We all have different opinions, and everyone is very vocal about how they read the data. Some feel like this worked, they tolerated it, why not keep going? And other oncologists feel like you can't get better than a past CR. Dr. Patel?
It's a great question. I think this answer is determined by what you gave up front, right? So if you gave Checkmate 816, 3 cycles of chemo Nivo, you got a past CR, you're done, right? If you gave, let's say, Keynote 671 or a GN 77T, was your mentality. You gave 4 cycles of chemo IO, and so by the book, we would give at least a year of IO therapy. Now, let's say someone had an IRAE, they had adrenal insufficiency, some other colitis. Could you take a perioperative regimen and make it pre-op only because that IRAE and feel pretty good about the past CR? Absolutely. But in the curative intent setting in medical oncology, we like to go by the playbook, and so it depends what play we called at the line. We can't audible.
Oh, we do lots of audibling. Come on.
Yeah.
Dr. Broderick, anything different?
No, my comment in tumor board is usually, I'm glad I don't have to decide.
Yeah. Yeah.
You know, and we actually had a very, very similar case just recently. From, we did the operation, but the systemic therapy was given at an outside institution, and that oncologist asked us to present it at our tumor board for the recommendation, and it was like 3-3. I mean,
Yeah, I don't know that we know here exactly.
yeah, I think it's just a patient-level discussion with the treating oncologist about the advantages and potential disadvantages, and what they're
Yeah, I
comfortable
definitely
with.
had patients who, and I actually think this patient was one of them. She wanted it. She wanted it, and she wanted it. And she was like, if there's any chance for more therapy and I'm doing great, I'll take it. And she had tolerated it well. No one was saying no.
Right.
All
I
right.
also had a patient recently who said, a year doesn't sound so great. How about 6 months?
Maybe the sub-Q.
Yeah.
There you go.
There we go. All right, I could ask you guys to please scan the QR code and vote again. Hopefully we've been super influential. And I think we go to our next case.
Great. So this gentleman is my patient, a 44-year-old man. He was coughing, and remarkably, he had a 14 by 8 centimeter mass in the left upper lobe, crossing the fissure a bit into the superior segment of the lower lobe. He had the mass sort of extending into the hilum, which we'll show you in a moment, with an FDG avid AP window lymph node. He's a super fit guy. His FEV1 was 3.3 liters. Diffusion capacity was normal echo. He had a percutaneous biopsy outside, which we reviewed, and it just showed a very poorly differentiated non-small cell cancer. PD-L1 was negative, and there were no targetable alterations. We did an EBUS, so we had stations 4L, 7, and 11, all of which were negative, but obviously we couldn't reach the station 5 node and a negative brain MR. So there's the imaging with this big left-sided tumor encroaching on the hilum there. In the middle panel, you can see that AP window node on the CT, and then a little bit of both on the PET there. So what would be your treatment strategy for this patient with what's clinically a T4N2 non-small cell lung cancer? Option 1, definitive chemoradiotherapy followed by immunotherapy, so the Pacific regimen. Upfront exploration, biopsy the level 5 node. If it's negative, do the resection. Neoadjuvant chemo followed by resection, even if it needed a pneumonectomy. Neoadjuvant chemo IO followed by resection, even if we needed a pneumonectomy. Or neoadjuvant chemoradiotherapy followed by resection. And then you could always cop out and say you're not sure. Bars are still moving a little bit, but I think we see the preponderance going with the neoadjuvant chemo IO followed by surgery, even if it needed a pneumonectomy. Dr. Donington, what do you think?
So I would say with these kind of T4 tumors, it's the one time where like the oncology purist in me goes away. You know, was it okay to not prove disease at that station 5 lymph node? But I think in this era, you know, the difference between, you know, you have a T4 tumor, it's not going to change our treatment per se. So it is the one time when I'm not going to do the VATS or the robot and go biopsy that node. If the tumor was 2 centimeters, we would do, you know, an outpatient procedure, biopsy that lymph node, get out and have a tumor board discussion. In terms of this in a fit patient, I have become much more comfortable with left pneumonectomies than I ever was before. I used to be one of the true haters, and I have really looked at the European data in these trials, and they've done these quite safely. Do I feel as comfortable with a right pneumonectomy? Not yet. It'll be a long time before I feel that, but I think I would be pretty happy with a neoadjuvant approach, and I think this is a surgical candidate.
I think at our institution, this is likely going to be a discussion between perioperative chemo-IO versus specific. And since I'm flanked by 2 surgeons on stage, I'm going to go with the perioperative chemo-IO approach. But I think, you know, for a young patient, very sounds like good host factors. The PD-L1 negative is not as reassuring, but the idea that we could potentially still get PAT CRs in patients with neoadjuvant chemo-IO, I think makes sense. If the patient, you know, was 84, right, maybe not interested in surgery, I'd be very comfortable giving them Pacific as well. But I think in this case, we'd probably lean to neoadjuvant chemo-IO perioperative approach in this case.
How do you counsel patients about the risk profile of chemoradiation in this scenario, where you have a big, bulky tumor, you radiate it, you're left with sort of a nasty cavitary mass in the left lung? And
No, I actually think the size of that tumor and its location would not make our radiation oncologist super happy. That chest wall is going to see a lot of radiation. It is going to leave a giant cavity that's going to be a mess. I don't think the radiation oncologist would be arguing with us terribly on this case.
Yeah, and I think to add to that, this a 44-year-old saw those late sequelae of radiation, very much, you know, could develop. And it's a tough radiation field based on that distribution of disease.
Yeah, it's a big field.
Yeah, and so I think a neoadjuvant chemo-IO surgery followed by IO would be reasonable. Let's say the patient didn't respond, though. Then thinking about a salvage radiation approach, maybe a different chemotherapy backbone followed by durvalumab, kind of the MDT bridge kind of approach in terms of clinical trial, especially for a young patient, may be reasonable. But I think, you know, for a young patient, in this case, neoadjuvant chemo, IO, and perioperative approach would probably be our initial thought.
So that's what we did. 3 cycles, carbo-pem-nivo, which he tolerated well. It did require a pneumonectomy. As it extended down into the hilum there, I just could not get that off the PA, and there was initially tumor in the lower lobe on the initial imaging. So, and he had a great response to therapy. So he had minimal residual poorly differentiated tumor. It was actually, they found a single 1.5 millimeter focus of disease in that whole 14 centimeter tumor.
Wow.
And all the nodes were negative.
That's impressive.
So what would we recommend as the next treatment for this patient? Adjuvant immunotherapy. He has some residual disease. Adjuvant chemotherapy, adjuvant chemo with immuno, or surveillance only, or I'm not sure. I didn't get that done, Dr.
I think that's okay. I've never been very good at getting that whole lobe out through the utility port, or the whole lung out through the utility port.
Well, there we go. So adjuvant immunotherapy is sort of winning the day. The adjuvant chemo immunotherapy, we don't really have any trials to support additional chemo on the back end with immunotherapy. But he actually opted not to proceed with the adjuvant portion. He's got a really physical job and was worried already about the effects on his ability to work, and so he opted to.
Yeah, I think the discussion here is very similar to the first case. You know, we have a near path CR. It's a very nuanced discussion. It's a young patient. They'll likely tolerate it very well, but it is a year of therapy, and I think patients weigh in a lot here.
No, couldn't agree more. I think also here the strategy was 3 cycles of chemo-nivo, right? So it's checkmate 1-6, so you're kind of 3 and done. If up front, the patient said, oh yeah, a year of therapy on a kind of a maximalist mindset towards it, picking one of the chemo pembro, chemo durva, for example, would be very reasonable as well, or even chemo nivo with checkmate 77T. But I think this is a great outcome, and to the point, PD-L1 was negative, and you still got this really phenomenal outcome. And so the biomarker can be helpful, but the absence of it shouldn't be a barrier to taking this kind of approach.
All right, I think we want you guys to vote one more time. And while we're doing that, I think we move on to a very short Q&A. We have about 2 minutes. We have lots of beautiful questions in the chat. Thank you all very much. I'll just kind of run through some that are pretty quick. The first one asks about a time frame between the chemo IO and surgery. We used to have pretty firm time frames set by some of our trials that included radiation pre-op. I kind of aim for 4 to 6 weeks, but I am not married for 4 to 6 weeks. And if I have to extend up to 12, I'm okay. I don't know what to do after 12, but I don't think there's a firm window. And I don't know what too soon is, and I don't know what too long is.
I don't know what too soon is. I aim for 4 weeks. And I have had some folks with immune-mediated adverse events during the treatment where we had to push them off because of adrenal insufficiency or whatnot. And it's anecdote, but those felt harder.
Yeah, they might be.
In terms of the dissection. So
Right.
I aim for 4 weeks. But if it
And I eventually try to pick a time when we say we're going to have to decide because you are going to need some local therapy if you don't operate. And there is a question about that. What happens if you can't operate? You do need a local therapy. So there is a point when you are going to have to pivot to radiation. And we tend to look in the middle and then look again at the end. And if we have to pivot, we pivot. We do lose about 15 to 20% of patients with the neoadjuvant therapy. That's consistent from chemo alone to chemoimmunotherapy. This doesn't make it worse. And I think we just have to be willing to look at it and kind of have those conversations with the patients. There's also one that asks about who are those patients. I actually have found them to be the frail patients. It's usually not progression that has stopped me from taking a patient to the OR who I thought put down one of these paths. It tends to be the patients who are not so robust going in. So I've become a lot more sensitive to that in looking at these patients. It's not enough to say, oh, you're strong enough for surgery. You have to be strong enough for this and surgery, and they don't all make it. Let's see, with some of these we have addressed. Someone asked about if we knew which one of these agents was best and how do you decide? I think that's we're so happy that we have medical oncologists and we don't have to do that. How do you decide one from the other, and are there any markers to help you?
Yeah, I think it's really just the clinical trial data. If you want 3 cycles neoadjuvant only, then your choice is 3 cycles of chemo nivo. If your choice is a perioperative approach, then you're thinking pembro, nivo, or durva. If you're doing post-radiotherapy, right, durva is your choice. If you're doing adjuvant, atezo or pembro would be your choice. And so in terms of thinking about neoadjuvant versus perioperative, it's all these factors that come up at tumor board, patient preference, PD-L1 status, nodal status as well.
Yeah. There's also a nice question about, does it matter where the residual tumor is? Is having it in the primary tumor different than having it in the lymph nodes? And there was nice work out of the Checkmate 816 trial that showed it really didn't matter. That reading you get is for the whole tumor and the lymph nodes, and it doesn't seem to really matter which one is positive. Let's see. One talks about, the ability to give chemoradiation after someone's already had this chemo. We haven't had that much trouble. I would be interested in your experience. Even if we've given 4 cycles, we've seen, they usually change the chemo agents a little bit, and they can still get in that weekly chemo with the radiation therapy. We have not had trouble, but I don't know whether it's different in one of your institutions.
No, so I think the chemotherapy we can adjust. Carboplatin works just as well as cisplatin in the modern era. We can do weekly taxanes, pemetrexed, and so we can make it tolerable. Where we find intolerability is if this patient had clinical progression, their tumor's now larger, the radiation field's larger, and tolerating that larger radiation volume becomes a barrier for these patients.
Yeah, I agree. We've had a few patients who, started therapy on the outside and then were referred to us, which I think it's super important that the surgeon sees the patient up front and sort of makes that determination resectable or not, because they had started a neoadjuvant protocol, saw us, and we said, they're not really resectable, they're not a candidate for this, and then went to get chemoradiation. Most of the ones who we've treated in our own institution have done reasonably well, though. The radiation oncologists worry about radiation after checkpoint inhibition, but it hasn't sort of
I think
played
less
out
and
yet.
less. As the data comes in, it's appearing that they might not really be enthusiastic about giving checkpoints with the radiation, but we've seen more and more trials where giving it up front is not dangerous and actually may be beneficial.
Absolutely.
Like I said, there might be sandwiches for everybody on stage 3. All right, are we over time? I think we are. So I ask you all, to scan the QR code and do the final poll questions, and we will sit here as a group for this minute and look and see who our winners are, because there are some really good questions that came in, so I appreciate everyone in the room. Give us 1 minute while you fill out your code, and we'll ask for the winners. Otherwise, I ask everyone to visit PeerView, look for LA25, and complete your post-test evaluation for credit. You can also download slides in Practice Age and watch for replays, which will be available in 24 hours. Thank you all for joining. Thank you, everyone online also.
Thank you.
All right.